Good evening. I must start by congratulating Abbott for organizing this program. And we have been doing this program since the COVID times, 2021. We have been doing different webinars with eminent cardiologists, not only from India, but from Bangladesh, Sri Lanka, and other neighboring countries as well. So I have the pleasure of uh, introducing our eminent speakers, Dr. Rajat Kar, Dr. Mohammad Mahbub Hassan, Dr. Dhananjay Kumar, Dr. Partho Chaudhary, and we have an expert panelist in Professor Dr. Saidur Rahman Khan. We'll be discussing today on a very common yet complex areas of calcific lesions in treatment of coronary artery disease. As we know that the calcium is a bane in the PCI. It is clots or calcium. These are the two important areas which are difficult to treat, but technology being technologies, they are actually improving day by day. So we have different armatorium today of treating calcium and difficult calcium. So previously we used to refer them to the surgeons, but today we have, as interventional cardiologists, we have enough tools with us to actually tackle this calcium. And secondly, we have also this strategy to even find out whether what kind of calcium do we have through the imagings. We have the intravascular ultrasound, and more importantly, we have the OCT now to guide us. So every calcific lesion, I believe, should be imaged, and then a decision should be taken. So today we have a galaxy of cardiologists who will be talking about the cases, the strategies to treat complex calcific uh, lesions. So let me first introduce Professor Saidur Rahman Khan, who is our expert panelist. He is Professor of Cardiology, Director of Cardiac Catheterization Laboratory in Ibrahim Cardiac Hospital and Research Institute at Dhaka, Bangladesh. And the first presentation will be done by Dr. Rajat Kaur, and he is at NH Narayana Health, West Bank, Howrah. He's a consultant interventional cardiologist. And we have with us Dr. Mohammad Mahabub Hassan, who is also from Ibrahim Cardiac Hospital and Research Institute, Dhaka. He's also consultant interventional cardiologist. We have Dr. Dhananjay Kumar, Medica, Ranchi. He's senior interventional cardiologist there. And we have Dr. Partho Chaudhary, head of the department of Meditrina, Jamshedpur. He is also senior interventional cardiologist. So without wasting much time, I would ask Dr. Rajat Kar to start his presentation, and I would also request Professor uh, Saidur Rahman Khan to conduct the meeting and ask the relevant questions. And also, we would also encourage our participants to chip in with their views as well. With these few words, I would like to invite Dr. Rajat Kar for his presentation. Over to you, Dr. Kar.
Thank you, sir, for this nice introduction. My case is not actually on calcium, but there was calcium a little bit, but it was a case of CTO, RCA CTO. So, sir, should I present my screen?
Yes, sir.
Please do that. Please do that. Yeah.
Yeah.
Somebody can you mute the other?
I want to present from my side, sir. Please remove your presentation. I have made some corrections.
Okay, go ahead.
So good evening, everybody. I am Dr. Rajat Kaur from Narayana Super Specialty Hospital, Howrah. Today my case, a male patient, 73-year-old male patient.
You didn't, Rajat, Dr. Rajat, you didn't share the screen. Please share the screen.
Okay. Sorry. Sir, I have already shared it.
No, it's not in the screen.
Stop. Okay, sir.
Go back from the beginning.
Yes. So now is it visible, sir?
Yes.
Yes.
Yes. Okay. So my patient is a 73-year-old patient who was admitted in the medicine ICU with a complaint of pain in epigastrium for last 1 day, which was not responding to antacids, several antacids, proton pump inhibitor, and a sense of abdominal fullness. And in the medicine ICU, with the routine investigation, the ECG showed a normal sinus rhythm and bifascicular block with a Q wave in the inferior leads. They sent the troponin, HS troponin, high sensitivity troponin, and which came out to be more than 10. And they did a echocardiogram, and which showed that ejection fraction of 42% with the RWMA in the inferior leads. And they took an urgent, they sent an urgent refer to cardiology, and we decided to take the call. In my case, the hardware used for angiography, the 6 French Judkins diagnostic catheter. For PTCA, it was guide catheter of 6 French M plus 0.75. Caravel microcatheter was used and run through hypercoat guide wire. Pre-dilatation with various types of balloons like traveler, sapphire, and finally the Wolverine cutting balloon. And the stent was used Giant Sierra 3.5 into 33. And post-dilatation done through 3.75 into 12 millimeter of NC sapphire balloon. And this is the coronary angiogram of the left system. So you can see, sir, LAD ostial lesion. There is a 70 to 75% discrete ostial lesion. Distal RCA is being filled retrogradely from the left system. LCX was tortuous, but not with significantly diseased. And there was also lesion in the diagonal one, ostium of the diagonal one. And this is the angiogram of the right side. It's a long fluoro loop. So, sir, at this point, as you can see, there is a very short segment visible, and the RC was totally occluded. At this point, JCTO score was 2. The segment has a blunt tip that scores 1. Calcification was not fairly analyzed. I put score 0. Bending could not be visualized properly. So for this, score 0. And occlusion length, as compared with the left system coronary angiogram, there is a long segment occlusion that's more than 20 millimeter. So it scores 1. So JCTO score was 2, and it falls in the difficult category of CTO. So we started with the JR catheter, JR guide catheter, and with the run through hypercoat guide wire, and with the help of a Caravel microcatheter, it passed through. But as you can see, the distal vessel is not fully visualized, and the guide catheter support was not much. At these points, sir, actually what happened, we started with the JR guide catheter, and as the support was not much very significant, these guide catheters slipped into the LVOT and uh, went to the LV outflow tract, and patient suddenly developed PP waves, that is a complete heart block on the monitor ECG, and we had to give a very short period of CPR for like 10 seconds, and he regained the consciousness, and again the QRS complex was visible. TPI lead were actually said was put on the IVC to make the field clearly visible, but then it was negotiated to the RV, and we changed all the plan. We changed JR guide catheter and changed it to 6 French M plus 0.75, and now the catheter support was robust, and then the procedure again initiated, and fortunately wire passed through the same direction. Then we started daughtering with the 1.5 15 millimeter traveler, and the daughtering was smooth, although up to this point any perforation was not excluded. Then it was that balloon was pre-dilated at the occluded segment at about 14 atmosphere, and the faint visibility of distal vessel was observed. Then we went for a gradual pre-dilatation with the help of a Sapphire 2 into 15 balloon, NC balloon. And after pre-dilatation of the entire occluded segment, check shoot was obtained for any dissection or perforation. At this point, the distal vessel visibility was acceptable, but the lesion segment was not optimally prepared for stent deployment. Hence, we decided to go for a cutting balloon pre-dilatation. So, as you can see, sir, after 2 millimeter balloon pre-dilatation, we could see the distal vessel, and the guide wire was redirected through the direction of the RCA, and Wolverine 3 into 10 millimeter cutting balloon was deployed at 10 to 12 atmosphere with a very good expansion. And check shoots reveal no major dissection or perforation. Then, sir, we decided to stent. The vessel was prepared optimally, and Zion Sierra 3.5 into 33 millimeter stent was positioned and deployed at 12 atmosphere with optimum expansion. And check shoot after balloon deflation revealed TIMI 3 distal flow. Now, sir, this is why you use Giant Sierra. The stent has a reduced cream profile for better crossability. Uh, stent has elongated bar to arms length for support and greater post dilatation. As we can see that we can make 3.5 millimeter stent up to 5.5 millimeter also. And the stent has a single piece outer member that supports better pushability and trackability. As I mentioned, sir, it can be 3.5 millimeter stent can be increased up to 5.5 millimeter. And the coating remains intact up to the greatest expansion. That is, if we use 3.5 millimeter stent up to 5.5 millimeter, the outer drug coating is not torn and it is intact, and it has a better radial strength. And this stent can be used for a very short duration of DAPT for 1 month or 3 months also. The stent has robust data around about approximately 24,000 patient was analyzed. And that's why this is stent was used in complex cases like CTO bifurcation or left main. And after the deployment of the stent, we decided to post dilate it, and it was a 3.75 into 12 balloon with a higher atmospheric pressure like 18 or 20 atm. And this is the final result. It's a long RCA which was totally occluded. And hence this is my case, sir.
Okay, Dr. Rajat?
Yes, sir.
Yeah, can you hear me? Just my question, in your lab, what is your workers wear?
Sir, run through hypercode, sir.
Run through. Is your workers wear also, right?
Yes, sir. Yes, sir. Yes.
And for this patient, the troponin I was elevated.
Yes,
is
sir.
it?
Around 10, more
And
than 10.
and intra-MI, acute STMI, ST.
Acute,
It's an STMI.
yes, sir. Yes, sir.
STMI. So in an STMI situations, why do you expect that this RCA is a CTO RCA?
Sir, actually, sir, after performing all the procedure, we went through the previous history and previous records of the patient that was not available that time. And a 3-month-old ECG was there, and that showed again the Q wave in the inferior lead, sir.
Okay, but ST elevation was not there.
ST elevation was not there, sir.
So maybe the Q waves, maybe he has got a prior insult in the inferior wall,
Yes,
but
yes.
it doesn't mean that it was totally occluded. Now it has been totally occluded. So,
Probably, sir, I thought it was a acute on chronic total occlusion. Acute event on chronic total occlusion.
in that case, but the raising of the troponin I and also the appearance of the wall motion abnormality and also the symptoms, everything goes not in favor of a chronic total occlusion.
Exactly.
Rather,
Exactly,
it's
sir.
got a, maybe you can just tell it in young CTO.
Yeah,
and
yeah. Hopefully.
this is the reason why your workers were taking the workers where you have been able to cross the CTO age, right?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Apparently CTO age.
Yeah,
right?
yeah. Yes, sir.
This is the thing. So you know that in this sort or any sort of PCI, one mantra is very much important to remember for everybody, that they don't lose the way, whatever the situation.
Yes, yes,
right?
sir. Yes,
Don't
exactly.
lose the way, and especially for CTO, you know that you have been able to cross the CTO lesion, and then all of a sudden you have to pull out everything and you have to take a new catheter and you don't know whether you can cross the wire. So I think that your luck has been favored. But you know, if you have in case of CTO lesions, if you have some sort of flaps or dissections there already,
yes, yes, yes,
then
yes.
you would be in rather bigger trouble that what I have done actually. So
yes.
even keeping the wear, you can go. I'm giving I'm doing it sometimes, that whenever I'm seeing that I have to change the catheter, so even keeping the wear as much as possible distally through the wear, through this guide wear, slowly, and very eventually, most of the time, even through this guide wear also, you can change the catheter.
Okay.
Keeping the wear there. Sometimes it may not, because sometimes it can jump out, but sometimes you can try. You can try, and it is possible sometimes, because it's really very much important. Even keeping a 3.5 wire within the catheter also and the wire, you can go for it as you've taken the femoral route. So it's easier. In radial, a little bit harder, but as I am extreme radialist, all the time doing everything by radial approach, even I'm changing the catheter by the same guide wire, keeping the guide wire as much as possible to keep it there. That is possible. Okay.
Sir, should I take the amplas right from the beginning? Because I thought it was an acute occlusion. That's why I started with a JR. But
your chair is actually what has happened. You have pushed a little bit, and then all of a sudden the chair has been just slipped out, and all of a sudden it went into the LVOT or something. Right? You have pushed a little bit, and that is, accidentally it has happened. Otherwise, even by JR, whenever you keep the balloon, you'll take the balloon like 1.5 you have taken during inflation. If you push the catheter, JR catheter, because it is coaxial, it was coaxial. So push the little bit there, the JR catheter will be much more deeply engaged there. So even you might not need the Emplar's catheter for these sort of CTUs or apparent CTU or young CTU. You don't need that specialty thing, the specialty guide catheter for this one. Because accidentally it has happened, it has turned into, at that moment, everything goes wrong for you. Like the CPR and blah, blah things, everything has happened. So at that moment, you are just thinking of surviving the patient and so that the patient can come out. Okay. Anybody else like Dr.
Sir, my question is, Dr. Rajat, why didn't you took a dwell injection? Because it is basic necessity while doing a CTO. One should have a dwell injection. Otherwise, how you will define what is your next plan? If you failed anterogrately, then what will be your next plan? So I think without dwell injection, a CTO should not be proceeded. It is a must for a CTO.
Yeah.
They said because he has given some answer before that it may be an acute occlusion. So that's why he didn't go for
even though it is an acute occlusion, you are saying acute occlusion without dwell injection, you won't decide your next strategy.
The problem is that Dr. Partho, Dr. Partho, Dr. Partho, that for me, like to do a bifemoral approach for dual injection. It is because because being a very, very extreme radialist, I don't like the bifemoral approach for these sort of things. You can go for the radiofemoral, like one is femoral and one is radial.
So whatever approach you can take, but dwell injection.
I usually take the biradial approach. Rather than the femoral. I'm not going to use for these sort of things. Not at all, even for calcification and other things. But it depends on the comfortability of the operator itself. It's not that any comparison is there, but you know that radial approach is safer in terms of bleeding and other things. That's true. That's already has been established.
Sir, I have one objection with Dr. Partho. Basically, it totally depends upon the operator.
That's
whether you are taking whether you are taking the retrograde or not. Many a times you may not need retrograde injection.
Sir, actually dwell injection is necessary. Without that, how you will define your CTO?
Okay.
How will you define your CTO? How will you see whether your wire has been landed at the right artery? So dwell injection is a must. When your artery is not visible, without dwell injection, this is the basic for starting a CTO.
No. Dr. Partho, just listen. First, for defining CTO, you need a retrograde injection during angiography, not during procedure plasty. First, the second thing, when you are doing angioplasty, there are several means of knowing that whether you are in true lumen or not. The first, if you have crossed the wire and you are able to wiring the different branches of the vessel, you are in true lumen. You have to diagonally, you have to search the diagonally opposite vessels, the diagonally opposite branches, and just wire the opposite branches. If you are able to wire the diagonally opposite branches, now you are in true lumen. The first, the second, if you have microcatheter, you are in the distal bed, you are aspirating the microcatheter, and if there is blood, you are in true lumen. If there is blood, you can inject a small amount of dye in that true lumen, and you will definitely get the true lumen. So
Sir, rather
in
than
many
doing these
cases, you may not
experiments,
need retrograde injection.
I will still suggest whenever you are going for CTO, take it seriously and always take a dual injection. Rather than doing these experiments, it will give a clear view how you should approach.
Dr. Partho, yeah.
How you should approach.
I
CTO
truly
should
accept
always be
your
taken
point.
seriously.
Okay,
Always
okay,
you
okay.
should take a dual injection so
Okay,
that
Dr.
you can
No.
properly
I am
define the
Let's go.
I am
strategy.
not.
Dr. Dhananjay,
I am not.
Dr. Partho.
Sir.
Okay, okay. Just because time is already 10 minutes.
CTO
15
should
minutes
always
ago.
be taken seriously.
I'm taking that. I'm
No.
just taking all the points here, because I'm really for last 10 years I'm a CTO operator. I love doing CTOs, and thousands of CTOs I have done. You know that when you are an extremely experienced operator, sometimes you may not need a dual injection, but in a
Dual
textbook
injection, yeah, definitely.
CTO, textbook cases, in textbook approach and orthodox approach is better. It's always better take the dual injection, so that there will be no perforation, dissection, or subintimal space
hematoma.
wiring, everything. It will life will be very much easier.
No.
Okay, so
Yes,
that's
sir.
the thing.
Yes, sir.
That's the issues.
Yeah.
Okay,
I
Dr.
accept these
Binayak,
points.
Dr. Binayak, Dr. Binayak, are you here? Okay, because we are just out of time now. The next presenter, Dr. Nimabu Hassan.
Yeah, Dr.
Yeah.
Hassan, yes, I think the points which you mentioned is pretty valid about the how to cross the CTO. I think, even the image guided options are also available to us now. I was guided crossing, but as one of the panelists mentioned that, to do a injection during this angiogram, that is also a very valid point, I think. So let's move on to our next presentation.
Dr. Mabu, are you there?
Yes, sir.
Okay.
Please share your presentation. Thank you.
Yes, sir.
Go for the share option there, down. Not here. Not here.
Hope my slides are visible and I'm audible.
Yeah. Go for the slideshow, down.
Yes, sir.
Okay.
Hello, everyone.
Okay.
Welcome, everyone. I am Dr. Mahbub Hassan from Ibrahim Cardiac Hospital. I'm very much delighted for getting the opportunity to present in front of such an august gathering. Now I'll talk about the pathogenic rocks in the coronary. We know calcium is the biggest enemy in the field of the intervention cardiology, but with the advent of modern imaging, now we know that there are different types of calcium. It may be superficial, it may be deep, it may be eccentric or concentric, and the most dangerous one is the calcified nodule. Calcium impedes the stent delivery and prevents the stent expansion, leading to stent thrombosis and restenosis. Nowadays, we have different in our hands, like high pressure balloons, scoring balloons, operational atherectomy, and the more costly device, the sonic pressure wave lithotripsy. Even though it becomes difficult to overcome this problem, like using multiple devices. Now, I would like to share a difficult case that we have done a few days back. And this story is about a 75 years old lady, diabetic, dyslipidemic, presented with TEMI and Herceptal. His ejection fraction was 45%. She is a known case of CKD with eGFR 35 ml per minute, and hemoglobin percentage was 8.5 gram per deciliter. Our precise DPT score was more than 25 and meets the ARC HBR criteria. And that means it's a case of SCS with high bleeding risk. Actually, this case is an imported case. This case is imported from our hospital, from another hospital by air ambulance. After presentation, she underwent a coronary angiogram in that hospital, and we can appreciate the heavily calcified lesions. And actually, usually the thin calf fibroatheroma and plaque rupture produces the SCS. But in 2 to 7% cases, chronic coronary calcification may produce the acute thrombosis. They tried to fix the target lesion LAD here first, but after waiting, they took stent. The stent stuck in the proximal part of the LAD. With further attempt, the stent balloon comes out, and the stent remains hanging over the left main. Now we can see the hanging part within the hanging part of the stent in the left main. I think they're fortunate enough that the distal flow is preserved, and there were TIMI3 flow everywhere. Now, our struggle, the first hurdle is to retrieve the stent garbage. As usually, we start with the right radial approach. As our center is an extreme radial center, we took the help of the 6-man gel guide. Initially, we tried with the micro snare, but did not work. Then we started snare. After a long struggle, we were able to catch the stent. Then we drag it up to the neck and arm with gentle controlled traction. When it reaches the tip of the sheath, then it was removed along with the sheath. And this is the villain of this drama, the trapped end. Then what should be our next step? Will you fix the LAD first or the circ first? And our surgical colleagues left the scene as it is a case, STS case. This time we start to the left radial approach. The LAD is not only calcified, but also there is an acute angulation, about 90-degree bend in its osteoproximal part. And what about the circ? It looks severely calcified, and there may be a nodule, calcified nodule there. And we smell the chaos and complexity. Initially, we tried to predilate the lesion. 2.5 NC balloon inflated well, but there were some dog boning in the middle. We plan to put a stent, TO stent in the LCX, but the underestimated calcium of the sarc is root phase. Then we took the scoring balloon, and yet we failed. We struggled enough. Lots of done for LAD 2. Then, what will be our next strategy? Will we ablate or shock? As it was a balloon proximal lesion, and we didn't want to take the risk of embolization. We took a 3O into 12 millimeter IVL balloon, and 30 pulses were delivered. After that, we easily crossed PO stent. Post validation was done, and this is the final picture. And yes, now come to our Volvo. By this time, we have learned many things and got alarmed by the behavior of calcium in the sac. It's going to be a sleepless long night to fix the LED. Again, same problem. We could not cross the IVUS catheter. Then we took some NC and scoring balloon. After NC and scoring balloon application, shifted with slow flow. But here, mid LED lesion remain unchanged. Then we took the IVL catheter, but we cannot cross the mid LED lesion. Then we apply the shock in the proximal LED while manipulating more the IVL balloon was up. And then we remember our old friend, the rota, to make the procedure Tripsy rota. We took the help of 1.5 bar, rota ablation was done. And after that, we took the cutting balloon to dilate and cut the calcium more. That means this procedure makes rota cut. And rota cut is a acceptable technique combining the rotational atherectomy with cutting balloon angioplasty. It resulted in similar MSA compared with non-compliant balloon angioplasty after rotablation. Now we will able to introduce the IVUS catheter. Now we can appreciate the equitense calcium with is posterior accosting shadow, and there was some reverberation. That means there are enough crack there. After this, we stented the mid LED lesion into 2.75I into 3 and proximal LED with a 3 stent, and the osteoproximal LED is stented with a 3.5 into 50 millimeter. Yes. And this time XB was our guide cath, and final IVUS and final picture after post dilation. Distal TIMI 3 flow achieved, and MS was optimal. Every day we're learning new thing where we are dealing with coronary artery calcium. For this case, there will be lots of ifs and buts. Upfront roadblock for both SARC and LAD may be an option. Hemodynamics, frailty of the patient, and faster coming out with success sometimes may drive one in more complex path. This case ended up with reasonable success, but with lots of struggle and with lots of cost. Thank you, everyone. This is all about me. Hello?
Yeah. Okay, Dr. Mahbub, thank you for your case. Dr. Binak, can you start with that one? Because this case also I was involved and I was the main cook here. And that's why I want the points and remarks from the other people.
Yeah, I think it was a good case. And let me start with our panelists first, our other presenters. What do they think? Maybe Dr. Dhananjay Kumar is a good friend of ours from Medica. So what do you think about this case, Dr. Kumar?
Good evening, sir.
Yeah, good evening. Good evening.
Sir.
Yeah. Your voice is breaking, Dr. Kumar.
Brilliantly managed, sir. Doing a primary case and he gets this type of calcified. Sir, I'm traveling and I'm in middle of the.
Okay, so okay, we'll go to Dr. Chaudhary, Dr. Partha Chaudhary from Jamshedpur. Dr. Chaudhary, your comments. Hello. Hello.
Hello, can you hear me?
Yeah. Yes, Dr. Chaudhary, we can hear you, please.
Probably LAD was a thrombus-laden artery and it was an infarct-related artery. Is it true?
Yeah, Dr. Hassan.
Dr. Mahbub.
Dr. Mahbub.
Dr. Hassan, can you hear me? Just I want to know that LAD is the culprit artery, it is thrombus-laden artery, and it is infarct-related artery. Is it true?
Yes, and it is the IRA. Patient present with STEMI and receptor.
Usually, rotablation, there are only two contraindications for rotablation. One is dissection and second is thrombus-laden artery. In spite of that, you did excellent work. Usually, thrombus-laden artery doing rota, it is very risky. It leads to dissemination of thrombus. Still, you did rotablation in a thrombus-laden artery. I think it was a bailout procedure and there was no other thing that we can do in that artery. And even distally, there was not TIMI 3 flow. You did an excellent work. Appreciable.
I think this is a thrombus-laden, but is
I can't hear
different from
you.
the other SCS. Is a calcium calcification in some cases may produce the thrombus. In 2 to 7% of the chronic coronary calcification may produce acute thrombosis.
Yeah, you're right,
Usually,
Dr. Hassan. But there's a concern there. I think, as Dr. Chaudhary just mentioned, thrombus and calcium, they are not friends. They're actually opposite end of the spectrum. So obviously, it was a very, very difficult decision for you to make. But would you have any other option besides rotablation for decalcifying that lesion?
If I would have been in your place, I would have tried with a new IVL catheter. If I would have been in your place, I would have tried with a new IVL catheter. Because thrombus plus calcification, it's a contraindication for rota. If I would have been in your place, I would have tried with a new IVL catheter. Still, you did it. It is really appreciable. It is really appreciable.
I would again interrupt this discussion. Basically, if you have calcified nodule and there is high propensity of thrombus there in acute setting. So if you have a calcified nodule and thrombus and you have aspirated the thrombus, the artery is without thrombus now, you can easily do rota, you can easily do orbital, but be sure that there is no thrombus burden now. And
yes.
there are several instances where we all have done rota ablation in primary cases. There are several instances. First, the second is if you are doing IVL in a calcified nodule, even 1, even 2, you can give 120 complete shock to the calcified nodule and you may not be able to soften that calcified nodule. This is quite possible and I have experienced this. Basically, my case was similar. In one calcified nodule, I have used complete 80 shocks to that nodule, but it didn't soften. So many a times in calcified nodule, you don't have any other option rather than atherectomy. Either you do biased rotational atherectomy or you do orbital atherectomy. Your best option is orbital atherectomy in calcified nodule. But if you don't have orbital atherectomy at your place, then use rotational atherectomy with biased wire. And if again I am telling the same thing, if in primary you are seeing thrombus, completely aspirate the thrombus first and then do rotablation. There is no harm in doing rotablation. I have done several cases where in primary there was thrombus. I have aspirated that. I have heparinized and give GP2B3 inhibitors, and then I did rotablation. There is no harm in doing this because you don't have many options.
Yeah.
Yeah, just a query, Professor Rahman.
Yeah.
Would it be a strategy, as just our previous presenter was just talking about, that you aspirate the thrombus, clean the area, and leave it for a couple of days and do a staged PCI on this case? I mean, would
Yeah,
that be an
Doctor.
option as well?
Yeah,
Doctor Dhananjay, Doctor
Sir.
Dhananjay. I'm telling you now. The points are there that the patient has been presented in other hospital, not here. It's not a primary PCI case now because already they have tried. The stent was dislodged there, right? So they have done a lot of ballooning there, and possibly by that time, by that 12 hours, time has been crossed by that time after ballooning. And that's why the thrombus laden, but not that much thrombus, fresh thrombus was there, maybe. First thing. Second thing is that the thrombus aspiration catheter, when you are seeing that even a 2.5 NC balloon is not crossing there, IVUS catheter is not crossing there, how we can cross the thrombus aspiration catheter, right?
True.
So that's another issue there, because it's not the focal calcification or focal nodule there. It's a huge calcification. When we have seen through the IVUS later on, you have seen that from the proximal LAD up to the mid-distal LAD, it is a huge deep calcium, and somewhere some nodules are there. The beautiful point which Dr. Partho was telling, that another IVL catheter. Obviously, that one was the best option for this sort of cases, because I'm doing the regularly the IVL most of the time. Okay, but you know that the two IVL catheter for this patient would be too much, right? This is one thing. Maybe I can start with the LAD first, right? So in that case, the fresh catheter can go down, maybe, or may not be, right? Because there are some eccentric nodules there which you will have to shave off. And you know that even by rotablation, if you shave one of the nodules partly, but you can't crack the whole calcium, so you have to go for a rotatripsy. That is the best option to make a good optimal expansion of the stent and apposition of the stents. Okay, so for this case, we have to go for the tripsy rota, and obviously it has helped in LAD with the used catheter, that is, which has been used in the LCX. So up to mid LADs that it has been crossed, but later at that point where the nodule was sitting down, that was not crossed. So we have to take the rotablation, and IVL balloon was ruptured actually. So we have nothing to do there, and we couldn't take another catheter actually. And it was a 3 catheter IVL, but mid LAD was 2.75 rather than 3. So again, we have to take it 2.7 catheter also. And in our, in this part of the planet, it's really tough to convince the patient party for that one. So we have used our old friend, and actually it has been helpful. Maybe the IVL catheter, the new IVL catheter may not be crossed also, because its profile is a little bit bigger than the NC or the scoring balloons. It may happen also. And slow flow, a little bit was there. That is because of lots of manipulations and the calcifications and the way the ballooning and everything was there, a little bit slow flow. But what I have expected that maybe the total no reflow may happen. And for these 75 years old patients with frail, very much frail, may not sustain that slow flow for a little bit time even with ejection fraction 45%. But God helped us that it didn't happen that much. Slow flow has been relieved by the GTM and also a little bit GPI, like a very small amount of GPI we have given there. Okay.
That's very good explanation for this particular case, Dr. Raman. So I think let's move on to our next case by Dr. Dhananjay Kumar. Dr. Kumar, could you share your slides and start your presentation, please?
Sir, I'm extremely sorry. I'm traveling and I've left my. Uh, I'm not able to share my screen. Basically, I can
Okay.
just
Then we'll wait. We'll get
summarize
Dr.
my
Chaudhary.
case and
I think
let
we'll
you
wait a
discuss.
little bit, Dr. Kumar.
Yeah.
We'll ask Dr. Chaudhary to do his presentation, and in the end, we will hear your case. Okay, Doctor. So, Dr.
Should
Chaudhary, if
Yes,
you're
sir,
ready,
I'm
you can
ready.
start your case. Yeah, please
I'm ready.
share your case. Yeah, thank you.
Sir, are you able to see?
Yeah.
So let's start it. My slides are visible.
Yes, obviously.
Thank you very much, sir. So I am just presenting a case of a rotablation in case of a balloon non-crossable true RCA CTO. So that patient was a 70-year female, had a past history of stenting to LED L6. She was having high-grade angina, TNT strongly positive on maximum antiplatelet anti-anginals, diabetic and hypertensive. Just coming directly to angiogram. Uh, this is RCA angiogram. It looks like a non-dominant RCA, but as you will proceed with dual injection, you'll be able to see it was a huge RCA. Anyway, it's like just after acute marginal, there was an ambiguous cap, and it is sudden complete occlude, just cut off. This is the RCA. When you'll see, it was with dual injection. I'll show you. LED stent was patent. L6 was a non-dominant, and its stent was also patent. And there were collaterals from L6 to RCA. And that RCA was a huge, that proximal to mid 99% lesion, after which it bifurcate, upper branch is completely occluded, and it was getting collaterals, epicardial collaterals from L6. So as usual, we started with a Fielder FC wire, and it was a 1.25 balloon, and unfortunately it didn't crossed. Wire crossed the lesion, but even 1.25, 1.85 balloon didn't crossed. Uh, just proximal to the lesion, we dilated it with a 1.25 balloon, and just try to modify the plaque, but still no balloon, even 0.85, 1.25, we were not able to cross the balloon. Usually in such cases, the option is using a Tornus catheter so that we can modify the lesion. We didn't have Tornus catheter with us. So next step was to, if it is possible to cross the wire, to change it with a rota wire, and we can do a rotablation. This was the next option we had. Now the thing is, crossing rota wire is still difficult, because in such cases, even we were not able to cross the microcatheter. Every hardware it's came out, and this is the angio. You can see that distal vessel is faintly visible. So we tried to cross the lesion with a rota wire. This is the dual injection. You can see that wire was in the lower branch. So this is the huge RCA. It was a short CTO, and the wire was in the lower branch. So once we were able to put the rotawire with the help of micro catheter to a desired branch, we took 1.5 mm rota burr with about 1.5 to 2 150,000 to 200,000 speed. We tried to cross the lesion. Initially, the catheter there was not adequate backup, but by repeated to and fro motion, we were rotablator burr was able to cross the short segment CTO. Once a rotablation has been done, the things become very easy. Next step is we took after repeated burring, we changed the wire with a normal workhorse wire and took a 1.25 followed by 2.5 mm balloon. Once balloon dilatation was done, you can see huge RC has been opened up. Next, we placed wire on both the branches, and on the up, we took a 2.75 into 40 Zines expedition stent, and it was dilated to 14 to 16 atmosphere. And this is the result. So, thank you for your kind attention and take home messages. It is very frequent while doing a CTO that we frequently encounter balloon uncrossable lesions, and we don't have much options. Either we can do a plaque modification with a tornus, and next is if we can able to cross the rotawire across the lesion. Rotablation is a good choice in such cases. Thank you.
Okay, Dr. Parthu. I think it's a CTO, it's a true CTO, and you see that there is a bending there also in the small segment CTO, but it has got a bending, and I think that was the thing. It is a extremely fibrotic thing rather than a calcific one, possibly. Possibly, I'm telling because you didn't do the imaging. That's the thing that almost all the CTOs, when we are getting very much exhausted while doing or wearing, or sometimes to do the wear or balloon is not crossing. So lots of issues are there. At that moment, usually they're getting too much exhausted, even like the Europeans also for doing the left main. Only 40% they are doing the IVUS. The same way they're doing we are not doing the IVUS, even most of the CTO cases sometimes, right? Even after opening that one. But you know that for CTO cases, it's very much important also to go for an imaging, because for the true distal reference diameter, you have to know, because that for a long time underfed artery will give you a false impression that maybe smaller, maybe, you don't know the diameter well, right? So this is the thing for distal reference diameter, to put the real diameter of the stent. And even after stenting, if you do an IVUS at least, you can understand that whether the stent has been approached well or not. This is first thing. The second thing is that balloon uncrossable CTOs, right? You have some other steps. Algorithm is a beautiful algorithm is there. You know that initially, but just jumping to the rotablation is the last stent, or the LCA is the last.
Actually, sir, that we have tried to take a small balloon and try to burst it. That is balloon busting.
Yeah, that I'm telling, the granuloplasty first. The granuloplasty will help.
Yes, the granuloplasty we tried.
And also you didn't try with a guideline. I usually take the guideline in this sort of cases to deep intubate it, and it will give you much more support of the catheter to push the balloon. And usually 1.25 can't make a granuloplasty well, rather than a 1.5 10 millimeter balloon. If you can cross-elevate and do a granuloplasty, maybe you may not need a rotablation there, especially for the fibrotic lesions, rather than a calcific one or a nodular one. Then nothing will help, like the granuloplasty or whatever it is, because you don't know, but it doesn't. And geographically, at least, there is no calcification, but there are some focal calcification in the CTO, especially for the small segment CTOs. In my experience, also, you may not even predict angiographically a severe calcification like 1 to 2 millimeter. Severe calcified ring is there, which is just obstructing everything. Nothing is crossing there. Okay, so that is also possible. But still, I think in the long run, when a big artery is coming out from nowhere, it gives an interventionist the pleasure of its optimum levels at that moment, and that you have got after doing that one. That's a beautiful thing. Thank you very much for your case.
Thank you very much. Thank you for your nice comments.
Dr. Binayak, can we go for anybody else to comment here?
Dr. Partho,
I can hear you. Please tell.
Yeah. You have done brilliant job. Opening CTO with rotablation is like anything you can do for the patient. I would have done something different from you. I am not contradicting you. I am just adding some few things in the discussion. The first, whenever I used to do CTO of RCA, I usually take some a stable catheter. Like JR is never a stable catheter for CTO opening. Now you will never get that much support while crossing a balloon, crossing a wire. So I usually take either L1 or sometimes if arc is large L2. So this is the first I would have done differently. The second, while crossing the larger balloon, even in CTO 1.25 and 1.5 is a larger balloon. If you are trying to cross the CTO lesion, if your wire has crossed, if your microcatheter has crossed, you can easily cross 0.75 and 1 balloon, CTO balloon.
Actually, you haven't listened. Microcatheter didn't cross.
Okay, good.
And 0.85 already tried.
That there are two possibilities in such situation. The one, your catheter is not supporting. The first, and this is the common problem, no?
Actually, you try to understand. If someone is taking CTO in a balloon uncrossable lesion, he must have tried all the provisions that you are telling. CTO doing rotablation, CTO is always a last resort. So if one is using rotablation in a CTO, which is very risky, he must have tried all the resort. I think you should understand.
No. I am understanding all these things. I am not contradicting you. I initially said I am not contradicting you. I am just adding few things. We must say na ki we all have done CTO with rotablation. This is not newer, but before going for that, we have several other options, and we should try. If you have tried, it's okay. I'm not contradicting that you have not done, but we should try those things. Okay? Your guide support should be good. Your balloon choice should be lesser of lesser diameter, and if even after that you are not able to cross, then it's okay. Then you have choice of rotablet the lesson. It's okay. If
Yeah,
nothing
can we
I'm
move
not
on to a
objecting.
different issue now? See, because these are complicated cases, and a lot of CTOs, when they come to experts, they have already been tried somewhere else. So, can I ask the panel and the and the other expert opinion makers, how long do you wait after somebody has tried a CTO and they come to you? What is your duration? In Singapore, we used to wait. When we couldn't cross the CTO, the South Koreans used to come from Seoul. They used to say that we have to wait for 3 months. So, do you think that is still valid, or do you think you can do it earlier, Professor Raman?
Yeah, Dr. Minak, it depends on who has tried for that CTO. An expert
I think usually
an
it is
operator
done by
an expert
usually
operator.
it is done by
Actually,
a
it depends like
lower
what you
center.
did. Suppose you did harvesting, then you can wait for a long. Suppose you did a dissection, then you can wait 3 to 6 months to heal. suppose you have just failed to cross, then you can call you can call the patient when you are ready with all your hardwares. I think it depends what you did.
No,
If you did
question,
harvesting,
no. The question is
no.
because lots of cases, Dr. Binayak has taken a very excellent point here, because this is really happening all the time. And the question is that how much? Because you know that whenever you are seeing the previous CD, you are seeing that nothing is there, almost, right? Who is going to just put all the pics there, all the scenes there? Are you getting that one?
Sir, I'm not
No.
getting you.
No, not that much, because they will cut all the, because they are not giving all the necessary documents there, all the necessary scenes there, whether there was a dissection there, whether there's a flap there, they have made some sort of hematoma there, or they have gone to the subintimal space there. Not too much, right? This is one. Second thing is that you will have to, usually somebody says 6 weeks, somebody says 12 weeks. All right. So this depends on the CTO segment, and you have to do an angiogram first. And now, if the patient comes after 6 weeks or after 2 weeks, what he will do? You need a check angiogram and to see that actually what has happened there. Because the final angiogram shot, which has been supplied, that one may not be, most of the cases, in my experience, I can tell that I'm not seeing the final shot there, right? At least in that way. So you will have to go for an angiogram and to see and to verify that whether you will touch now or you will touch later. Right? Dr. Binayak?
Okay.
So I think that it is 9:41 now.
Yeah, I think Professor raised some valid points. I mean, because usually they try from the lower centers, where all the expertise is not there, and I believe that all these people who are not experts, they try a little more than they should be doing. So I think the consensus should be, that if you do not have enough hardware in your armatorium, in your cath lab, that's possible. That's nobody's fault. So I think we should refer it. We should have the courage to refer it to the higher centers where it's been done. That way, the expertise of the centers will increase also. And if required, we encourage the operators of these centers to come and join us and scrub with us. So that way they understand which cases they should do and which cases they should leave. That's point number one. Point number two is, I think calcium, we were supposed to talk more about calcium today. Can I ask, Professor, how much of orbital atherectomy are you using nowadays?
No, we don't have the orbital atherectomy. And actually, there is no head-to-head trial telling the superiority of the orbital atherectomy over duct ablation for calcification, especially, even for the nodule, whatever it is. You can shave off the nodule by rotablation also.
Yeah, only thing is that the learning curve is actually a little good for the orbital. The rotablation, it is not a difficult thing, but I think when people face the rotablation, they think it's a huge deal, which is actually it is not.
Yeah.
So yeah, I agree with that. And what is your experience with IVL?
Yeah, I have already done almost. I have almost made a century here personally.
Very good
for myself, and I'm feeling very good. I mean, and you know that the trials are coming, registries are coming for the nodules. Also, it is getting helpful. The IVL is going to.
But it has got its limitations also. Don't you agree? It has got its limitations
obviously, because balloon uncrossable lesions, or the lesions where even a 2.5 is not crossing, but you need an IVL of 1:1. How we can cross that balloon there? So
yes,
you have to go for
I think,
the
Professor, every cath lab I think should have their own protocol based on the guidelines. I mean, based on the availability of your hardware, because every cath lab cannot have the same kind of hardware.
Yeah, don't touch it. I usually tell my fellows, don't touch the calcium without having all these necessary things in your docket. If you don't have, please don't touch it. Like that,
so be it.
like that case.
What is your recommendation for CT angiogram prior to all these cases?
It's not that much actually, because when in disparate items, especially for the surgeons, they want it more, because when they want to decline it to go for a cabbage, then they'll look, the calcium is there, but not
Would you recommend for centers who do not
that
have
much.
imaging, to do a CT angiogram instead if they don't have imaging with them?
No, I don't think it's equivalent, because the imaging is giving you the internal lumen much more.
Of course,
because
yes,
that one is very much important.
Yeah, just a poor man's imaging, I would say,
Yeah.
So that's good. So I think Dr. Dhananjay cannot join us today because he's traveling. So Dr. Dhananjay, would you want to summarize your case just verbally so that we can do a little bit of discussion and then wind up the meeting? Dr. Dhananjay, are you there?
I think he has left, sir.
Okay, he has left. Okay. So I think we have had a wonderful three-case discussion here, and a lot of points were touched. And I must thank Professor for his very, very valuable opinions on this. And we would love to have this kind of interactive sessions more and more, because we learn. Everybody learns from each other, and we also learn how to tackle lesions in a manner, I think, which is guideline oriented. The more experienced you are, I think we follow the guidelines more. Would you agree, Professor?
Yes, actually, because it comes through that way. Because whenever you are getting experienced, you know that actually you are following the guidelines even without reading that one.
Yes,
I've
exactly.
seen that one.
Yes. So I would thank all the presenters and professors for taking out a valuable time for this meeting. So if there are no more questions, I think we'll wind up the meeting for now. Subhabruto, could you give a vote of thanks?
Yes, sir, you can wind up. Yes.
Yes. Okay, so I would like to thank everybody, and also Abbott for organizing this kind of meetings. So please, we will see you again sometime, maybe physically, somewhere in one of the conferences. Okay. Good night, everybody.
Thank you, and happy Friday night. Happy Friday night for you.
Thank you very much, sir. Thank you.
Most welcome.
Thank you, sir.